Okay, Apurva and Madan, go ahead.
Good evening, all. On behalf of Sexual Medicine Committee, Foxy, I welcome you all in this new series of our webinar Spectrum. So first, I would like to welcome the person behind all this program, our own Dr. Neeraj Jadhav, sir. Sir doesn't need any introduction. Sir is the committee chairperson of the Sexual Medicine Committee, Foxy. Sir is the past president and secretary of the Rajkot OBJ Society. So over to you, sir, for your kind words and insight and the vision behind this series Practicum.
Thank you, Apurva. So I'm counting my last few days for this committee, and Apurva will take over from me, and we will continue. Our change of guard will not affect our activity. We will continue with the same program and so many new activities also. So good evening and welcome everyone to today's practicum series, which we are, as Apurva told, we are starting from today. Why this series? Because this is series, sometimes we know so many things about any dysfunction or problem, but when the patient come to our clinic, we face dilemma. What should we do? How to evaluate such patient, how to manage such type of patient, and how to take follow-up and of such patient. So we started this series with that thing in mind. So basically, what we are doing, we will do in this series, we will pick one topic and we will invite one faculty for that dysfunction or any related matter. And we want to know how this faculty or our expert manage such type of patient, because we want to learn from them, because they have so much vast experience in the field of sexual health and sexual medicine. So we want to learn how they manage such type of patient, how they evaluate this patient, and how they take follow-up patient. If one modality of management fail, how they change over the modality of the management. So this is the basic idea. So today we are starting our first session with the very most common, I say that common sexual dysfunction we encounter in our day-to-day practice, that is erectile dysfunction. Because we saw so many patients which come to our clinic, which they think they are facing because of erectile dysfunction. Maybe it is their perception, they are not actually patient of erectile dysfunction, but we have to evaluate whether they need management or they need counseling, and they don't require any medical management. So I hope with today's session, your all doubt about the how to manage patient of the erectile dysfunction will be clear, and you will get practical tips and tricks about the erectile dysfunction. So with this thought, I welcome once again everyone for this learning, and happy learning to everyone.
Thank you so much, sir. First of all, to start this program, and these all web series are brainchild of yours, sir. And your tenure is not at all finished. Sir, you will be the super boss, and we will work under you, under your guidance, sir. So thank you so much, sir. I think Chief Guest ma'am is yet to arrive. So we start with the guest of honor. Okay, sir?
Yes, sir.
So we.
Apurva, you are muted. Unmute yourself.
When we start any auspicious thing, we are always getting blessings from our seniors. So we have very esteemed guests.
Muted again. You are muted, Apurva.
And I would like to welcome Dr. Charmila ma'am. Ma'am doesn't need any introduction. Ma'am is a very dear senior, a mentor, a friend, a senior of mine. Ma'am is the Vice President elect for 2024. Ma'am is the Governing Council member ICOG and also the elected governing council member of ICOG. Ma'am is the past chairperson of the Clinical Research Committee, FOXY. Thank you so much, ma'am, for accepting our invitation. Over to you, ma'am, for your kind words and blessings.
Thank you, Apurva. Yeah, thank you, Apurva. It's like the enthusiasm which you show is so infectious always. So good to hear your voice with so much enthusiasm. There are some committees in FOXY which do not have the patronage of big pharma. They do not have the support of much of seniors, and you have to work alone. And I think Dr. Neeraj Jadhav has shown the way for Sexual Medicine Committee. It was not so well known before he had taken over, and the way he has worked over the years is a great thing, because I had a similar problem with Clinical Research Committee because nobody used to fund any of our programs. We have to work alone, strive alone. But the way you have taken Sexual Medicine Committee to such great heights is something which needs to be emulated. And I know that Apurva will do the same work which you have done in the past 3 years. And I would say that the way you worked for the ICOG certificate course was an eye-opener, because no other certificate course was conducted with so much of precision, and you had planned it meticulously, and it was on time, and you had got such great attendance, which nobody expected for sexual medicine. And that was a great thing. And many of us learned so much, because we all tend to treat infertility only. We don't treat the sexual dysfunction. And the topic which you've chosen today is a great topic, because many of us just shift the patient to the andrologist and then go ahead with fertility treatments and do not bother about how the couple is facing psychological problems in their family life. So the topic is extremely important, and I'm very eager to learn from such great experts, and I'm eager to learn from the faculty, Dr. Rahul Reddy, who has joined us, this person today, for the resource person today. And I'm happy to see Dr. Shaman Seth will be the Vice President in 2025. Thank you, Dr. Neeraj, for the opportunity.
Thank you, madam.
Thank you. Thank you so much, ma'am, for your kind words, for your blessings, and always your guidance. Thank you, ma'am. So our next guest of honor is again very dear senior and a friend of mine, Dr. Shamal Seth, sir. Shamalda, thank you so much for coming, for always your blessings. Sir, again, doesn't need any introduction. Sir is the Vice President-elect FOXY for 2025. Sir is the past chairperson, MTP committee, and sir is the past secretary and vice president of Bengal Obji Society. So thank you, sir, for accepting our invitation. Over to you, sir, for your blessings and for your kind words.
Thank you very much, Apurva and Neeraj Bhai. Apurva is a dear brother of all of us, and and from myself, I don't want to be senior. I always want to be a junior, a friend, a colleague, whatever you can call, but not a senior ever. But this is a very important topic, erectile dysfunction, and in most of the cases, maybe we as clinicians, we are the providers for the patients who come to us for the complaints of erectile dysfunction. There is no single medicine which can cure all the patients, because in most of the cases we do not know the exact reasons. So whatever treatment we give is kind of empirical treatment. Some of them work nicely, some of them may not give the satisfactory results. Maybe some sort of improvement would be there. Will be come across by the male partners. But in most of the cases, in today's life, when both the partners are going through overuse of their brain, they are over anxious, under tremendous stress and strain of day-to-day life. Maybe both of them are working and they are leaving their house in the early morning, coming back in late night or mid of the night, and they have got hardly any time to have a good reaction or interaction or good talks between them. Sometimes this good mutual conversation works like a magic, and that's not happening in day-to-day life among many couples. So all these things we need to explore. I think our speakers will be able to make us more enriched in knowledge on this topic, erectile dysfunction, and what could be the better and able pharmacological agent which we can use for the treatment of these patients who have been suffering from erectile dysfunctions. Thank you very much, Apurva. All the best for your tenure. You are going to take over in next 2 months. And Neeraj Bhai, excellent. It's a huge congratulations, and we are all happy the way you worked during your tenure. Thank you very much for calling me and inviting me to be a part of this program. And I would like to go through all the interactions which are going to happen in this program. Thank you very much, Apurva and Neeraj bhai.
Thank you, Samalda.
Thank you. Thank you so much. Thank you so much. Neeraj sir, should we go ahead with
Yeah. Yes, sir.
with
Yes,
the conversation? So, my dear friends and colleagues, now the wait is over. We are eagerly waiting to have the practical tips, the tricks, and all the footfall of the today's topic, that is erectile dysfunction, by none other than but our faculty, Dr. Rahul Reddy sir. Reddy sir again doesn't need any introduction. Reddy sir is a famous andrologist and the chief consultant of the Androcare Andrology Institute, Hyderabad. Sir has a lot of awards in his name and have given lots many of topics, and sir is usual faculty for our programs. Thank you so much, sir, for always being there, for always taking and accepting our invitation. Over to you, sir. We are eagerly waiting to hear and learn from you. Over to you, Rahul sir.
thank you, Reddy sir, for joining us, because whenever I ask for anything, you are always committed in saying yes. So we are heartfelt thanks to you for accepting our invitation.
Sir, I should thank you for inviting me, sir. So at the outset, I would like to thank Neeraj sir and my dear friend Apurva for always encouraging me. Yeah, I think they have been encouraging me from the beginning days of my career, and my association with Foxy continues. So coming to the topic, I think during the last year's session, we discussed about erectile dysfunction management in gross. Now, in this topic, I would like to tell you about practical tips in management of erectile dysfunction, so that any gynecologist or any general physician who sees these patients in their regular OPD knows what to start and where to start. The common fear in most of the doctors is about starting PDE5 inhibitors. So most of the doctors fear that what might be the side effect, whether this patient may be having cardiac side effects, and what drug to start, and why to take all this headache of treating erectile dysfunction. This is the common scenario or common thing which comes into every doctor's mind, including me when I was into early urology days. So the moment we see a ED patient, we used to think of side effects of sildenafil. Those days. So now those days are gone. Now there are those days the understanding of erectile dysfunction is very less. Now the understanding is totally different. Now we can find out what exactly is causing this erectile dysfunction in that particular patient. It's always easy. Once we diagnose the root cause, then treatment is very easy. So now I'll start my slides with first couple of slides will be about basic evaluation. When you see a patient with erectile dysfunction, what tests you have to do and how to start management. So now we all know what is erectile dysfunction. Erectile dysfunction is inability to achieve and maintain an erection. Both achieving is important and maintaining is important. Sometimes patients, they get erection, but they lose erection immediately. So the maintenance part is also important. So now coming to types of sexual dysfunction or erectile dysfunction, we have 4 types of erectile dysfunction. One is hormonal, second one is psychological, third one is vascular, and fourth one is neurogenic. Neurogenic is very rare, and situational is sometimes again this comes under psychogenic cause. So now coming to hormonal erectile dysfunction, psychogenic erectile dysfunction, and situational erectile dysfunction, any doctor can treat. See, same PDE5s. So there are only 3-4 PDE5s. Everybody can start them. Start these PDE5 inhibitors. You don't need a urologist to start PDE5 inhibitors. So only severe vasculogenic causes where patient is not responding with basic dosage of PDE5 inhibitors, that is particularly vascular cause, those cases you have to refer to a urologist or endocrinologist. So there is one more part in sexual dysfunction, because many doctors don't understand that ejaculatory dysfunction is different from erectile dysfunction. Premature ejaculation is different from erectile dysfunction. Premature ejaculation comes under ejaculatory dysfunction. Sometimes even patient don't know what he says. Sometimes even though he is having premature ejaculation, he comes to us and say he is not able to maintain his erection. That is because of the premature ejaculation. So we have to ask them, whenever patient says that he is not able to maintain the erection, we have to ask them, he is not able to maintain erection after ejaculation or before ejaculation. If he says he is not able to maintain erection before after ejaculation, that is clearly premature ejaculation. Why this makes difference is, now if it is premature ejaculation or both erectile dysfunction and premature ejaculation, then we have to give medications for both. So now when it comes to erectile dysfunction, so it can be of two types. One is organic, second one is psychogenic. So we should be in a position to identify whether this patient is having a psychogenic ED or organic ED. There are very simple differentiating factors. Patients with organic ED, they won't have good early morning erections. He will say, I don't have good early morning erections. But patients with psychogenic ED, he says he is having good early morning erections. But when he tries to perform, he can't maintain erection. So that is the main differentiating factors. And same way, people with psychogenic ED, sometimes they get good erection, sometimes they don't. Even in organic, sometimes patients with low testosterone, they may get very good early morning erection. As day goes on, their hormone levels will go down. So by evening, they may not get a proper erection. So that is one differentiation. So now common causes of erectile dysfunction are performance anxiety, previous failure, depression, fatigue, guilt, stress, and marital discord. So this slide is very important in management. Why I'm saying is, if a patient fails once in intercourse, even if you give medications, his fear of failure will always subconsciously sits in his mind and causes next failure. So this can lead to premature ejaculation also. So those patients, they need some counseling. We have to talk counseling in the sense it's just reassurance. We don't have to send them to a psychiatrist for counseling, but just reassurance and ask them to take some medications. That is important. Otherwise, every time they have performance anxiety, it leads to failure in spite of taking PD5 inhibitors. Or else we have to give them high dose of PD5 inhibitors. So regular causes of erectile dysfunction are cardiovascular disease, diabetes, neurological cause, hypertension drugs, hormonal deficiency. They're all common. But what is important is, now in my recently we started a study. What we found out is vitamin D deficiency, vitamin B12 deficiency, and high homocysteine levels, which are very common in pure vegetarians. This is one of the major risk factor for erectile dysfunction. Now, at least 70% of patients in our study, they have high homocysteine levels and low B12 levels. So other ED is associated with diabetes, hypertension, heart disease, medications, depression, psychological factors. This is common. So now, evaluation wise, what we used to before is we used to do basic evaluation tests. Then we used to start ED management. Now it is not simple now. Now, suppose I'll tell you an example. Today, I saw a couple. The couple came recently married, around 3 months back, they got married. This guy's wife says he's having no interest at all. And the patient was not ready to come for consultation. He came to consultation, but he is not interested. He says, his attitude says that he is not interested in my consultation. But he says, doctor, I'm all right. I don't have any problem. I think my wife is worrying too much. Wife says his sexual desire is too low. So then when we evaluated, his homocysteine was almost 95, which is totally abnormal. Then and his B12 was around 40s, less than 40, and the vitamin D was less than 5. And the moment he came to me today, his total attitude changed because he read about homocysteine, he saw the reports, he Googled. The moment he Googled about homocysteine, it says about cardiac issues, stroke. Then the fear factor came in. Now the person who is not interested in treatment, now he says he has fear of life risk. The moment he has seen all these issues. So now this homocysteine test or high homocysteine levels, this itself will prevent future cardiac risk. Now,
Rahul
there
sir,
is no test in the world, there is no test in the world which will tell us about future cardiac risk. Now, only erectile dysfunction evaluation can tell us what is his future cardiac risk. So, all those evaluations like cardiac evaluations like diabetes, ECG, 2D echo, they can tell us about present problem. But if a patient is having organic cause, vasculogenic ED, that means we can say that this patient may have future cardiac risk. This is the only way we can assess their future cardiac risk. So now even that is why we say now ED is strongly associated with cardiovascular disease. If a
Reddy sir,
patient is having,
Reddy sir.
hello,
Sir, sorry to interrupt you, sir. Just
Hmm.
Dr. Asha Bakshi ma'am has joined. So just we will get 2-minute blessings from ma'am.
Yeah,
sorry,
no problem, no,
sorry for interruption, sir. Just,
no problem, sir, no problem, sir. Yes.
Asha ma'am. Yeah.
Should I?
Thank you so much, ma'am. Ma'am is always there. Thank you so much, ma'am. You always give time to our webinar and with your kind words and blessings. Ma'am doesn't need any introduction. Ma'am is the Vice President Foxy and committee in charge of ours. And over to you, ma'am, for your blessing.
First of all, wishing you a very happy Diwali in advance. And it is impossible not to connect to your program because you really invite me with so much love and affection that I can really not deny it. I have to attend. And so it's nice to see Dr. Rahul giving such a good lecture with lots of enthusiasm and energy that I can see, and that's apt for the erectile dysfunction. So excellent program. Please go ahead, and thanks again for inviting me, and very good work, Neeraj, Jadhav, Dr. Kamble, and the whole team. Keep doing, and blessings to all. Thank you so much.
Thank you. Thank you so much. Thank you so much, ma'am. Rahul
Thank
sir,
you, madam. Thank you.
yeah,
Yes.
please go ahead, sir.
So now what has changed in erectile dysfunction management is we have to do basic evaluation. Then if we have to rule out their future cardiovascular risk. If there is any risk, then we have to take physician's opinion, or we have to refer them to a general physician or cardiologist. Once we get clearance, then we can start medications. But if it is simple hormonal ED or psychological ED, we don't have to refer these patients. Only patients with vasculogenic ED, arteriogenic ED, then we have to refer these patients. So now we say that penis is barometer of endothelial health, and erectile dysfunction is a mirror of cardiovascular risk. So erectile dysfunction is equivalent to endothelial dysfunction. So there are so many studies which says that endothelial dysfunction can cause erectile dysfunction, and the causative factors for endothelial dysfunction are again same risk factors like heart rate, hypertension, atherosclerosis, smoking, diabetes. So the causative factors for cardiac and ED and cardiovascular disease both are same, like increasing age, male, hypertension, diabetes, obesity, smoking, dyslipidemia, and sedentary lifestyle. So now 57% of men who had CABG or bypass surgery had prior history of ED, and 64% of men hospitalized for MI had prior ED. So that this itself will tell us why evaluation of ED is important. So now coming to basic evaluation, when you see a patient with erectile dysfunction, what test you have to order? This is the slide which will tell you. One is thyroid profile. Second one is testosterone. Total testosterone is enough. We don't have to do free testosterone. prolactin is important, and vitamin D, vitamin B12, homocysteine, HbA1c. And my initial evaluation is this one. Later, if patient, then I will start management. If patient is not responding with my medications after a month, then I will ask for penile Doppler study. Because penile Doppler study, there are so many fallacies. It's an observer dependent. It depends on the experience of the radiologist who is doing penile Doppler. And there is an injection which is involved in the penile Doppler. We have to give a pepaverine or bimix injection to the penis. And most of the patients, already if they are having psychological issues, the moment you say there is an injection to the penis, they are worried. So you have to postpone or reserve this penile Doppler test for a later time. First, you do basic evaluation, all our blood works. Then, based on the, see, if it is vitamin deficiency, you have to correct vitamins. If it is testosterone deficiency, then we have to correct their testosterone levels. I will tell you how to correct their testosterone levels. So now, coming to treatment options. So now, what treatment options we have? We have medical management. Primarily, this is PDE5 inhibitors and nutraceuticals like L-arginine, ashwagandha, safed. There are so many other nutraceuticals which we generally use. Sometimes they use zinc, sometimes they use vitamin B12 supplements, and hormonal treatment. Injection therapy. Injection therapy means intracavernosal injection, which is trimix or bimix injection. If it is not working, then shockwave therapy and surgical management. These are the treatment options we have now. So now, what are the non-pharmacological treatment options? This is nothing but lifestyle modification. So we have to ask them to go for regular exercise, if possible, weight loss, tobacco. If there is any substance abuse or smokers, we have to ask them to stop smoking and alcohol. So coming to exercise, the common question which is asked by patients is what type of exercise they want. Because the moment you say exercise, most of them, they go to gym, they pay a monthly or annual fee, they go for 1 week, 10 days. After that, they stop it. So this is not sustainable. So what I found out in my practice is a regular brisk walk is more than enough to improve their testosterone levels. So brisk walk for 4 kilometers a day or at least 5 days a week, that is more than enough. They don't have to join any gym, and then weight management, weight training is not important. So second thing, the moment what we have to understand is the moment these people join a gym, most of the weight trainers or gym instructors, they will ask them to take protein powders. And the most common protein powder what they give is whey protein. I don't know what is the exact reason, but I get at least 3 to 4 patients a month who comes to me saying that, sir, after starting whey protein, I'm having erectile dysfunction. So there are no studies, but what I assume is the moment they start whey protein, because testosterone is a protein bound, testosterone transfer is protein bound. Most of this testosterone is gets transferred to the muscle. So that is the reason I think the moment they start whey protein, and people, that is common with low testosterone. Already people having low testosterone, if they start whey protein, probably they end up with sexual dysfunction. So now, indications for PDE5 inhibitors. One is psychogenic ED, mild vasculogenic ED, neurogenic ED, and patients having side effects from other medications. So now, what are the PDE5 inhibitors we have? We have now 5 types of PDE5 inhibitors. Sildenafil, we all know Viagra is the common brand name which is available, but there are so many Indian brands which are available. So it is available in 3 forms: 25 milligrams, 50 milligrams, and 100 milligrams. And tadalafil is available in 4 strengths: 2.5, 5, 10, and 20. Remaining medications are not easily available. Sildenafil 100 milligrams and 200 milligrams. I think only one company is producing this in India. And vardenafil came into Indian market, but only 2 companies are producing. Sometimes it's available, sometimes it's not available. Avenafil, again, 2 companies are producing it in India. So it's available in 100 milligrams and 200 milligrams. But commonly available medications are sildenafil and tadalafil. So now the use of each PDE5 inhibitor is different. If patient says, doctor, I want to perform only once in a week, just give me a tablet which is enough to have intercourse, then you can actually start sildenafil 50 milligrams. Or if he is not responding, he can take maximum up to 100 milligrams. But we see patients taking 200 milligrams of sildenafil, 300 milligrams of sildenafil, which is actually on paper, which is not advisable. And we are not supposed to prescribe more than 100 milligrams, because tomorrow any legal issue is there, then we are maximum dosage, prescribed dosage is 100 milligrams. So the quality of erection you get with sildenafil is much better than tadalafil. So it is an on-demand. Sildenafil is an on-demand drug. Tadalafil, if it is taken in low doses, it helps in improvement. So generally, it causes vascular dilatation, relaxation. So if a patient wants a daily dosage, tadalafil is the best drug which is available in the market. So, and the side effects, if you compare with sildenafil and tadalafil, there are very less side effects for tadalafil, and you have advantage of starting on very low doses. If you can start with 2.5 milligrams once daily. Most of the patients respond positively without any side effects. Any patient who walks into your clinic says erectile dysfunction, without even doing any investigation, you can start low doses of tadalafil, either 2.5 milligrams or 5 milligrams, because 5 milligrams of tadalafil is actually approved for BPH management also. That too, long-term management of BPH. So no major side effects. But same tadalafil, if it is given at 10 milligrams and 20 milligrams doses, it works like on demand. So now there are so many permutations and combinations. You can give daily doses of tadalafil, or then on demand you can take sildenafil. So it all depends. So let us see basic efficacy of all these drugs. Only advantage with tadalafil, if you see, start time to efficacy is almost same to all drugs. Only vardenafil it is around 60 minutes. The rest of the tablet starts working in 30 minutes time. But if you see the time of efficacy, all other drugs, sildenafil, vardenafil, avenafil, they work for only 3 to 6 hours. But tadalafil, it works for 24 to 36 hours if it is taken in a high dosage. That is why this is called weekend pill. Sometimes patient wants to have intercourse only on the weekends. If they take around 10 mg or 20 mg on the weekend, it works for 2 to 3 days. That is why it's called weekend pill. So side effects are same, contraindications are same for all these things. Only patients who are taking nitrates, it is contraindicated. Otherwise, there are no major contraindications. And tadalafil can be taken as daily doses. The rest all medications are on-demand medications. Okay. So now coming to selection of PDE5 inhibitors, I told already how to select. Now, if a patient is having psychological ED, or patient is having says he is not having good early morning erections, or unmarried patient comes to you says, doctor, I am not having erectile dysfunction, I am having erectile dysfunction, you can start them on tadalafil. You can start with 2.5 milligrams and slowly ask him to titrate. What I do is, initially I used to give him 2.5 milligrams once daily, and next month if he comes back, I used to give him 5 milligrams. Now what I started doing is, I'll ask them to take this 2.5 milligrams for 5 days or 10 days as a 2.5 milligrams dosage. And if he is not happy, I will ask them to take 2 tablets at a time, that is 5 milligrams after 10 days. So that after a month, by the time he comes back, you will know whether this patient is responding with tadalafil or not. Now, if he is not responding with 5 milligrams of tadalafil on daily doses, I will ask for pediatric doctor. And if penile Doppler is already done, it says there is mild arteriogenic ED. Again, even in these patients, tadalafil 5 milligrams will work. 2.5 milligrams may not work in these patients with mild arteriogenic ED. You have to start with 5 milligrams of tadalafil. And only possible side effect with this tadalafil is back pain and myalgias. So you have to counsel the patient. In case there is any back pain or myalgia, ask him to stop it for 5 days and restart it for after 5 days. Generally, this side effect may not be there after 5 days. And if patients with severe vascular ED, then tadalafil, low dose of tadalafil may not work in these patients. So they need on-demand of medication like sildenafil or avenafil. Sildenafil, either you can start with 50 milligrams and 100 milligrams. Avenafil, it is around 100 milligrams or 200 milligrams. So you can try two things. You can continue them on low dose tadalafil, and on the day of intercourse, you can ask them to take sildenafil and 50 or 100, or else same tadalafil low dose, and we can ask them to take 10 or 20 milligrams of tadalafil on the day of intercourse. So this is how we have to start the medication. But patients with non-consummation of marriage, when you see a couple with non-consummation, by the time they come to you, they must have tried all these tadalafil, low dose of sildenafil. There, already the patient must be having severe performance anxiety. There, giving low dose medications may not work. Directly start with 100 milligrams of sildenafil, so that once he have intercourse, his confidence will come back. So then you can decrease the doses of sildenafil, and slowly you can stop sildenafil and we can start tadalafil. So now, for a regular practitioner or for any gynecologist, tadalafil should be your drug of choice. Whenever you see an erectile dysfunction patient, you start them with 2.5 milligrams, take it for 10 days. If it is patient is not responding, you can ask him to take another 2.5 milligrams from day 11 onwards. But if he is not responding with 5 milligrams of tadalafil, even after a month, then ask for penile Doppler, or else refer this patient to a local urologist or andrologist. So these are the common side effects: headache, flushing, dyspepsia, myalgia, back pain, nausea, nasal congestion, visual disturbances. Visual disturbances are common with sildenafil. So only point what I would like to highlight in ED management is, most of the patients, the moment you prescribe medications for ED, there is a common notion in the patients say that all these allopathic medications are not good for heart. That is the reason most of these patients, they try allopathy, homeopathy, allopathy, and all alternative, Ayurvedic, and then they come to us. So first thing we have to do is reassurance about the side effects. We have to tell them, those olden days there are severe side effects, but nowadays whatever medications are available, these medications are safe. So once we reassure patient, at least though there are minor side effects, if you tell them these are the possible minor side effects, at least he will have confidence of taking medications. Along with these medications, along with this, these are the contraindications: organic nitrates and severe cardiac disease. You are not supposed to prescribe PDE5 inhibitors. So along with these PDE5 inhibitors, you can give them L-arginine up to 2,500 milligrams to 3,000 milligrams. You can start on daily doses. In some patients, because L-arginine is supposed to be a nitric oxide precursor, people with early arteriogenic ED are particularly diabetics, hypertensives, people with endothelial dysfunction. Giving tadalafil along with L-arginine will help in most of the patients. Young patients, we don't have to give them L-arginine. They respond with tadalafil alone. But patients with vasculogenic ED or diabetics, hypertensives, better start them with L-arginine. So coming to penile injection therapy, I don't recommend this in your practice, but these are the other treatment options which are available. If a patient is having non-consummation of marriage, a couple is having non-consummation of marriage, and if you think that only psychological severe psychological performance cause or performance anxiety is alone causing is non-consummation of marriage, what we do is we ask them to come to hospital. We give this penile injection. Once we give this intrapenile injection, this patient will have erection for 1 to 2 hours, and then we ask them to have intercourse. Or if he is staying close to your hospital, you can give them this injection and you can ask them to have intercourse. But once they have intercourse, at least this will boost their confidence. Then, even though the patient is not responding with PDE5 inhibitors, sildenafil, because of his performance anxiety, once they have intercourse, then they start responding to these medications, because once they have intercourse, that boosts their confidence. So coming to hormonal therapy, this is again very important. Now we see in your regular practice, most of the quacks, the moment they see a patient with erectile dysfunction, they put them on testosterone injections. That is why most of the people, they go to quacks, they come back with azoospermia. They come with HPT access suppression after taking this testosterone injection. And there is no limit for testosterone. We see patients taking 10 injections, 20 injections. Sometimes we see young patient, unmarried patient or recently married patient, continuously on testosterone injections for 1 to 2 years also. So that will suppress their sperm production. So testosterone, any form of testosterone, whether it's a gel or injection like Sustanon, Cernos or Cerno gel, all these are contraindicated if they are planning for conception. So if testosterone is on the lower side, then you have to increase it with either clomiphene citrate, or if there is abnormal TE ratio, then you can put them on anastrozole or letrozole. Or else you can actually put them on ashwagandha, other medications, but strictly testosterone should not be given. And even in patients with testicular failure, once they conceive, and if their testosterone levels are on the lower side, or if they go for IVF, and after the IVF, then you can start testosterone injections, because they can't take clomiphene for lifelong. So you have to differentiate patients is for in fertility as into fertility age group and non-fertility age group. For non-fertility age group, then you can start testosterone injections. There are no long-term side effects. Only thing is you have to monitor their LFT levels and hematocrit values. Only 2 things you have to monitor. Apart from that, fertility age group, testosterone injections, any form of testosterone is contraindicated. So these are the treatment options. One is clomiphene citrate, or letrozole or anastrozole, alternate days, or gonadotropin injections, HCG 5000 once in a week, and direct testosterone is always contraindicated. So now patients who are not responding, I think the major part is done. Only few slides about further management, where patient is not responding with medical management, or he wants permanent cure, then at least in these patients, shockwave therapy works. There are many studies which says that if you carefully choose a patient with early arteriogenic ED or early endothelial dysfunction, they respond positively with shockwave therapy. They need 4 to 6 sittings. But even this has come in. Now, most of the quacks started using this shockwave therapy. There are so many n number of Chinese machines which are in the market. These machines are hardly 50,000 to 60,000 rupees. And we don't know what kind of shockwave they generate, but they are charging 50 to 60,000 rupees per patient. Most of the quacks, they have some sort of shockwave therapy machine. We don't know what brand, what machine, whether that is the reason now for quacks, this has become like one more money spinner. So patients who are not responding with any of these things, then there is surgical management. We do implants. So implants, we have 2 types of implants. One is malleable and inflatable implants. These are all malleable implants. This is inflatable processes. After implant, with malleable implants, they'll have 24/7, they will have erection. So, but they can bend it. So hiding is easy. There are no long-term complications. And most of these implants, they stay for 15 to 20 years. We don't have to frequently change the implant. This is how we do a pineal implant surgery. And after the malleable processes, this is how a penis looks. Always they will have erection, but they can bend it. Thank you, doctors. Now I think we'll start question and answer session. Anybody who are having questions
Sir,
or
can you
any
stop?
case scenarios,
Yeah.
we can discuss.
Yeah, you can stop sharing, sir.
May,
Sir, you
may I
said,
ask-
yeah, wait.
may I
You
ask
said
a
about the, yes, sir, Rahul, sir. You said about the
Yes.
evaluation part where you advise thyroid, testosterone, prolactin, vitamin D, B12, homocysteine, test for diabetes. Then, do you advise all these tests in when patient come, or it depends upon the patient?
It depends on the patient, sir. Sometimes if patient psychogenic, pure psychogenic, I generally start them on tadalafil, ask them to come back after a month. If patient says he's very good, then slowly I'll decrease the doses. I'll start tadalafil on alternate days or once in 3 days, and I'll ask them to stop.
No, no, sir. I am asking about the blood test. Do you this whole battery you advise in when patient come, or that thyroid?
Now, sir, now see, by the time patient comes to me, sir, he must have taken treatment from multiple doctors.
Okay.
So from my side, I do all those things in the beginning only. But if it is already done, we don't have to. But if it is not done, then those things I'll do it.
Okay.
If patient has already taken high dose sildenafil and comes to me saying that, sir, there is no erection, then straight away I'll go for penile doctor.
Okay.
Can I ask one question, please?
Yes, ma'am.
Yes,
Yeah. See, I'm an infertility specialist, and many times we get these patients with performance anxiety.
Yes.
So what would you suggest? We usually give them 50 milligram of sildenafil. So is this
Okay.
dose okay, or you think that no, we should give more or something like that?
No, 50 if they are responding with 50 milligrams, it's okay, madam. Otherwise, then we can give them 100 milligrams. Or else, as I said, you can start them on tadalafil, low dose tadalafil daily doses.
Okay.
So daily doses, then they will get very good early morning erections and spontaneous erections. Their confidence will increase. So
Right.
the performance anxiety part will go away completely. Otherwise, if you put them on sildenafil, there is a common issue with sildenafil. Today, if you start sildenafil, after some time, patient thinks that only when he is taking sildenafil, he is getting erection.
Okay.
Slowly, it starts like an addiction. After
And what
some
about
time,
tadalafil? With that, there is no addiction?
no, it's not an addiction, madam. It's psychological addiction. Patient thinks
So,
he gets an erection, but
okay,
tadalafil, it's you can give him on long-term basis
long
also.
term.
You can give for 1 or
I-
2 months. By the time he gets confidence, then you can ask them to stop.
Okay.
I want to know one thing.
Sometimes I do one thing, madam. Only on fertile days, I'll ask them to start. Some patients comes to me and say, sir, other days I'm okay, it's okay. Only if doctor says these are the days you have to have intercourse, those fertile days, they'll have ED. So
Yeah.
that fertile days, daily give 5 milligrams of tadalafil for 1 week or 10 days and ask them to stop after some.
Yeah. For IVF purpose, usually we have a frozen sample, but still, I
Yes,
think
ma'am.
it's not a bad idea to give tadalafil. So I think that's a good thing. Thank you.
Yes.
I want to know one
Yes,
thing.
sir.
That is what, as said by the former people, I usually start tadalafil 10 milligram per day for 10 or 15 days, and then I maintain it at 5 milligram daily for 2 to 3 months. Now, what you told is to start with 2.5 milligram initially and then to go for 5. So, which
Yes.
one should be advisable or rational according to your opinion? To start with 2.5 and then to switch 5 milligram daily, or what I do in my practice, I start with 10 milligram daily for 10 to 15 days and thereafter to continue with 5 milligram. Which one is more rational or more efficacious?
Yes. Sir, the moment you start 10 milligrams,
Yeah.
even with 2.5 milligrams, myalgias are very common. So if a patient gets a myalgia with 10 milligrams, then he won't even take. Even if you say 2.5, take 2.5 mg, he won't take. That fear will be there. So if you gradually increase the doses, you are avoiding this side effect complication.
That's the reason only that there is a more possibility of getting myalgia with 10 milligram dose. No other
Yes.
problem.
No other problem.
Okay, that's a
Back pain and myalgia.
And another thing is that, I mean, what is there any personal experience of yours on that prosthesis? As it's very interesting.
We do everything. It's almost every week we do one case, sir. One or two cases will be there.
I was not aware of this so long. That's a nice lecture you did, Dr. Reddy, I must say. Thank you very much. It's immensely helpful for all of us. Anyway, that's good enough. Now, what those implants are made of?
Silicon, sir.
Silicons. Okay.
Silicon implants.
Okay. So nice. Thank you.
Reddy sir, when you put patient on the PDE5 inhibitor, then
Yes.
how will you monitor? You call them monthly or 2 monthly, and then in future, how will you monitor that patient?
No, I call them once in a month, sir.
Okay.
Once in a month.
Even if it is
if
giving satisfactory result, you call them every month?
No, see, patient don't have to be on tadalafil for long time, sir.
Okay.
I'll wean off, sir. After 1 month, if he says patient is doing well, psychological patient or hormonal patient, once the hormones and vitamins are normal in the normal range and they are getting good erections, then we don't have to continue, sir. Slowly I will wean off. I'll make, if his patient is on 5 milligrams, then I'll start giving 2.5 milligrams and then I'll ask them to stop.
But again, they will not develop ED if you stop the.
No, gradually, if you stop gradually, sir, by that time, since patient is having regular intercourse, his confidence levels would have been, that performance anxiety factor would have been very less. Since there is no failure in last 1 month, he thinks things are all right. He's improving. Then I will decrease it to 2.5 and then slowly I will stop.
Okay.
We don't have to continue these medications for lifelong. Only patients with arteriogenic ED, there we have to continue medication.
Okay. So how much time they can continue if it is arteriogenic?
Arteriogenic lifelong also they can take, sir. Lifelong also they can take. Okay. But it all depends on their sexual frequency, sir. I'll ask them how frequently you want to have intercourse. If patient says daily I want to have intercourse, then 5 milligrams daily is a better choice. If patient says I want only once in a month or once in 10 days, then SOS medication is better, sir. I will stop 5 milligrams. I will ask them to take 10 milligrams or 20 milligrams only on demand during the day of intercourse.
And one another, sometimes patients tells that I have already taken sildenafil, but it is not helping. So you go directly for the penile doctor, or you advise and counsel them how to use properly and then go ahead.
No, sir. If patient comes to me saying that already he has used multiple medications and still there is failure, I'll directly go ahead with penile Doppler test.
Okay. If it is showing arteriogenic ED, then you put on PDE5 inhibitor, right?
PDE5. Okay. PDE5 inhibitors may not work, sir. See, most of the patients, they come to me after taking all PDE5 inhibitors.
Yes.
So if in penile Doppler, if PSVs are very low, if they are less than 10, then there is very less chance of these PDE5 inhibitors working in them, sir. Either I will put them on injections or I'll counsel them for implants, penile implants. Okay. If there is no response with PDE5.
Okay. And sometimes patient ask if they is cycling is a cause of ED. What's your opinion? Cycling can cause erectile dysfunction?
Yes, I have seen multiple patients. So cycling is known to cause low testosterone.
Okay.
Most of the cyclists, what I have checked is they have low testosterone levels, and low testosterone level can cause EDs.
Okay.
But direct vasculogenic cause, I don't know.
Okay. Is there any question?
I think there are multiple questions. Some questions are there, sir.
Yeah. Just go ahead.
Success rate of penile implant, sir, almost 97%. The only problem with penile implant surgery is infection, like any other implant surgery. If there is no infection, generally nothing will happen. There are no major complications. And the cost of the implant, it depends on the type of implant. It starts from 1.5 lakhs to 10 lakhs.
Sir, there is a implantable devices also available, or it is not.
But they are very expensive, sir. They are very
Okay.
expensive. Implant itself will cost around 6 to 7 lakhs.
Okay.
Only implant cost.
Okay. Implantable one.
And basic investigations, one more question. Any medication for psychogenic ED? Previously, we had apomorphine, sir. Apomorphine is a wonderful drug which can be given along with these PDE5 inhibitors. But I think it's not available in the Indian market. Jadus has this drug called Jaiprima, but it's not available.
Okay.
So we put them on, what we do is for psychogenic ED, we counsel them and we put them on high dose PDE5 inhibitors. And once they have successful intercourse, and then we continue them on low dose PDE5 inhibitors for long terms. Any brand name of sildenafil, there are so many hundreds, sir. Suhagra, Kamagra, Sildegra, Penegra, Kevarta. There are so many brand names.
Yes, yes.
Tadalafil, Efil, Modula, and Tedox, many brand names. Tadalafil, I think the moment you don't have to write any brand name, you can just write sildenafil and write doses. Pharmacy people will give medication. These are commonly available medications.
Okay, sir.
And basic investigations for erectile dysfunction, I think we discussed. Vitamin D, B12, homocysteine, testosterone, prolactin, and thyroid. These are the basic investigations.
There is one question, sir. For patient with a cardiac problem or with other systematic problem on medical management for the same having ED, can handle with medication?
Yes, sir. No problem.
Okay.
They can handle, sir. Except nitrates.
Yeah.
All other medications can be taken along with this.
What about
and one more.
minoxidil or alpha blocker?
One minute.
If a patient is
One more question.
yeah.
What to do if PE is coexisting? So
Yeah.
premature ejaculation, if there is premature ejaculation, what I do is along with tadalafil, daily doses of tadalafil, I put them on either fluoxetine or paroxetine. Fluoxetine 20 milligrams once daily, or paroxetine 10 milligrams daily. Both are SSRIs, they work very well. And there is a on-demand drug called depoxetine. Depoxetine 30 milligrams. So patients who want only on-demand medication, then they can take 30 milligrams of depoxetine along with 10 milligrams of sildenafil. There are so many combination drugs also, sir. Same tablet, you get 10 milligrams tadalafil and 30 milligrams of depoxetine.
So, sir,
This
what
is
is
good
better? You give what is better if you give fixed drug or you give different drugs in combination? What will be the better idea?
both are safe. Both are safe.
Okay. And what about
And
the
the
minoxidil or yeah, sir? There is one question. What about the minoxidil or alpha block induced erectile dysfunction? What is the best treatment for such type of patient when patient is on alpha blocker?
Okay. See, alpha blocker. See, only alpha blocker which have to be avoided are tamsulosin and sildenafil, sir. And for us, only problem is with dutasteride or the other one. What they give for hair loss treatment. See, problem with these drugs is that they block the testosterone receptors. The effect of these medications will stay for 6 months to 2 years in some patients. We don't know why it stays. In some patients, the moment they stop, they will be all right. So in some patients, it stays for 6 months to 2 years. slowly most of these patients, they will improve. So there are no specific medications which work in these patients except increasing their testosterone levels. And there is one drug which is a natural drug which helps in these patients. What I have seen is fenugreek extract, methi extract.
Okay.
Fenugreek has saponins, natural saponins. These saponins, they work like steroids. Actually, previously we used to say when there is receptor level problem, then we have to give some steroids. We have to, but steroids itself can cause problem. So, but fenugreek saponins, they work like steroids. They improve free testosterone. So that is the reason, along with these drugs, I give them fenugreek.
Fenugreek raw or this extract. Hello. Sir, fenugreek means how much?
No, market, there are medications like fenugreek extract. It's separately available, around 200 milligrams should be ideal, sir.
Okay.
But there are so many drugs for erectile dysfunction which comes along with combinations, sir. L-arginine with fenugreek extract.
Okay.
JDS has a drug called Eractex, and there is one more drug called Himract, Reasonrex Pro. There are multiple combinations are there.
Okay.
They come with fenugreek extract.
Sir, how you handle
Finasteride,
the? Yeah. Yes, sir.
previously they even the dermatologists, sir, they initially they used to give 5 milligrams of finasteride. Now they are giving 1 milligram. But even with 1 milligrams, 1 milligram finasteride, there are side effects. People are coming with sexual dysfunction. So it's better to avoid. But minoxidil comes in spray or local solutions, here local application solution. So instead of minoxidil as a topical solution is much better than tablet.
Sir, how you handle erectile dysfunction patient with already on nitrates?
So there, the chances of it's better not to start PD5 inhibitors. Only thing, legal issues are there. Generally, we ask them to take their cardiologist opinion. In those patients, generally we put them on bimix or trimix injection or vacuum pumps. Vacuum pump works in them.
Sir, just a few details more line about the vacuum pump because it was not covered. Just can you elaborate more on vacuum pump?
Okay. So see, it's a I think I have a picture, but it's a small handheld pump, vacuum pump. So they have to put the penis in the pump and they have to start the vacuum. Or else sometimes it comes like a BP apparatus where we just have to press for creating vacuum. And once it sucks blood into the penis. And once a blood comes into the penis, then we have to put a small rubber band kind of thing at the base of the penis and they can have intercourse. But it is cumbersome to use.
Yes.
Most of these vacuum pumps are actually designed for Western people. Their girth of the penis is totally different. Indian penis and the people with the east, from the east, their penis size is small and girth is small. So that is the reason most of the people, they have problems in using these vacuum pumps.
Madan, is there any question we have not covered? For psychogenic erectile dysfunction, what is the preferred drug? I think you have covered that.
Yes, yes.
Hmm.
So penile Doppler is done by specific sonologist or it is done by routine sonologist. There are very few radiologists who does penile Doppler studies because it's a time-taking study. Many radiologists, they don't show interest because they have to give injection. Sometimes there is risk of priapism. And if whenever there is priapism, again, patient will go back to them. They have to give phenylephrine. So many radiologists, they don't show interest. And it's a time-taking scan. So radiologist, if he's already trained and if he's doing, then it's okay. And if patient has headache, what to do? Then if patient, after taking PDE5 inhibitors, if patient is having headache, one, you can actually give them basic anti-inflammatory medications or painkillers and then give these medications, or you can actually change the medications. You can change that PDE5 inhibitor. If patient is having headache with sildenafil, you can give vardenafil or avenafil. So whichever tablet patient is comfortable, they can continue that.
Sir, one more question. I think evenafil you can take with the meal, all other are, you have to take on empty stomach, right?
Yes. See, there are differences in these PDE inhibitors, sir. Tadalafil can be taken anytime. Only sildenafil, out of all these PDE5 inhibitors, only sildenafil has to be taken on empty stomach.
Okay.
Rest of the medications can be taken after food also. But in my experience, most of these medications work better on empty stomachs. And people who are taking alcohol daily, there are some patients who regularly take alcohol. Tadalafil is not advised to take along with alcohol. But sildenafil can be taken. So if patient is taking daily alcohol, and then either you have to change the timing of sildenafil, tadalafil. So what I do is I ask them to take in the morning. Morning after breakfast or after lunch, I'll ask them to take tadalafil, and evening they can have alcohol.
But then, is there any
Sir, yes, Rahul sir, I just want to ask
Yes.
you, the combination of tadalafil with depoxetine, whether it should be taken on daily basis or on demand, in case
No,
of
it's only on demand.
on
On
demand.
demand.
And
1 hour
if
before
plain,
intercourse.
okay, in major psychogenic part of ED,
Yes.
psychogenic component if there is more. And if we want to use tadalafil, it can be taken on daily basis. Okay.
Yes. Yes.
Okay.
you can give separately, I think, tadalafil daily dose and depoxetine on demand, right?
On demand we can use. Yes.
Yeah.
Yeah. I have used in 3 to 4 patients. I think I have used 5 mg dose of tadalafil.
Okay.
There was slightly lower response with 5 mg.
Okay.
Yeah.
So
But
then
it is
you
costly.
can use.
Yeah,
Tell
drug
me.
is very costly.
Which one? Tadalafil.
Tadalafil with depoxetine. It comes in a combination of 4 tablets.
Yes.
Yeah, plain tadalafil is coming in 10, a strip of 10.
So tadalafil is cost effective. Nowadays tadalafil comes for even 20 rupees.
Okay.
2.5 mg is only 10 rupees. And 10 milligrams is only 20-25 rupees. Most of the brands are around 20-25.
Okay.
In the olden days, even today, the original brand of sildenafil, which is Viagra, is around 400 rupees each tablets. And the original molecule of this one, tadalafil, brand name is Cialis. Even that is around 450 rupees, sir, per tablet, single tablet.
Okay.
So on demand you can give. So daily doses, if they are not responding, daily 5 milligrams you can give. Only a weekly ones you can ask them to take this combination drug. Or else instead of giving combination, you can give one tadalafil and one paroxetine daily. 10 milligrams paroxetine on daily doses for premature ejaculation.
Paroxetine is better or depoxetine?
No, depoxetine and it's like tadalafil and sildenafil. So
Yeah.
depoxetine is only on demand. You can't give it as a daily doses. So
Yeah.
daily doses, then it's better to take paroxetine.
I think we should add this drug if there is associated premature ejaculation only.
Yes.
Right. No?
Yes.
Any other question, Madan, in chat box? Just check. Then otherwise we will close this.
I'm not able to see any question actually in chat box.
I think we are completed, sir. All the questions are completed.
Okay.
Yes,
So
mostly.
thank you, Rahul sir, for giving
Yes,
us your precious time. And yes, Madan, you can go ahead with the vote of thanks.
Okay, sir. On behalf of Sexual Medicine Committee of FOXY, I would like to mention thanks to our beloved President, Dr. Rishikesh Pai sir, Madhuri Patel ma'am, Secretary General, and Vice President Asha Bakshi ma'am, and our dear one, Dr. Neeraj sir, Dr. Apurva, and today's chief guest and guest of honors, Dr. Charmila ma'am, and Shamal Seth sir, and our dear one, faculty, most esteemed faculty, who has thrown a light on this subject very well, and Dr. Rahul sir. And thank you, Rahul sir, and all the audience who have joined from all the societies of India. And it was really a wonderful session. And I would like to congratulate Neeraj sir for starting this practicum series. It is really helpful.
And sorry, sir, I forgot one question. I just remembered.
Yes, sir.
When
Yes.
patient comes, do you have any ready-made performa about history, or it's just how do you take history of a patient with erectile dysfunction? Do you have any fixed performa with you? We would like
No,
to
no,
have
sir.
that.
No,
Yeah,
I
just
have a case sheet like this, sir. I have a
so
case sheet like this.
can you share with
Everything
us?
is
We would like to use that performa with us. If you can.
yes, sir. I will send a picture, sir. This
Okay.
is actually my case sheet. So
Yeah.
I will send a picture. So you
Okay.
can actually change it according to your needs.
Okay.
According to my need, I have changed it. All these things, whenever patient comes, so though most of the doctors are going for regular online this one, but
Yes.
I am using this because I learned this from my boss. I am using
Okay.
this because the moment I see this case sheet, I know what drug I have written, for which drug he responded, for which drug he didn't respond. So
Yes.
this is actually easy for me. This is case sheet come my regular consultation papers.
Okay. Thank you.
This
Thank
I
you, sir.
keep this with me.
Okay, sir.
Sir, do you provide a questionnaire to the patient when the new patient comes in the OPD?
Actually, there are so many questionnaires, sir, but only problem with this, most of these questionnaires are confusing. For a normal patient with normal basic IQ, these questions are like twisters. Most of the patients, they find difficulty in actually coming to actual point. So
Yeah.
now what we do is we ask all leading questions, whether early morning erections are there. We are planning to prepare a basic questionnaire. I'll once that questionnaire is ready, I'll send.
Thank you, sir.
You
Yes.
what you can do is you can convert it into Hindi.
Yeah.
I am actually doing it in Telugu and English. You can
Okay.
convert it to Hindi.
It should be in local language.
Yes.
Yeah. Yes. Thank you, sir. Thank you.
And thank you to our ICOG chairperson for granting us the one ICOG credit point for this webinar. And thank you to the Medicine people who are giving this on their platform, this webinar they are transmitting on their platform. And thanks to all the delegates who have joined for today. So happy Diwali to everyone in advance, and have great festive seasons. With that note,
Happy Diwali to all.
yeah,
Happy Diwali, sir.
Happy Diwali to everyone.
yeah.
Yes, same to you, sir.
Very, very happy Diwali. You enjoy your festive.